Okay, so why is CABG better than PCI? So we're doing a different procedure. So CABG bypasses the proximal two-thirds of the vessel where not limiting lesion and future lesions exist. CABG provides protection against vessel occlusion through a surgical collateralization, and we treat areas, we don't treat lesions. And so high syntax score affects PCI, doesn't affect CABG at all. So at the top part, the CABG arm, there is no difference between the syntax scores at all. But if you go down, see the PCI, whenever there is a high syntax score, the complications are higher, the death is higher, MI is higher. So CABG is the only revascularization strategy with a proven survival benefit. Yes, there's a whole meta-analysis, but it's proven for survival benefits, especially for triple vessel disease, left main disease, and abnormal LV dysfunction. And this is a CAS left main disease also, and it does give an extra 6 years survival for patients, and that's why in 2001 the PCI was as class 3 indication. So blocking the left main pair with a stent. So this is after this large Korean registry that challenged the CABG superiority on left main. It does have also superiority in favor of CABG for target vessel revascularization. Syntax trial came afterwards, and it showed that there is a survival benefit for patients with a high syntax score, not for the low or intermediate. And after the subgroup analysis from this trial showed that also the CABG has superiority for high syntax score, and this was the inclusion for the Excel trial. And lots of non-inferior trials came afterwards, Excel, Noble, Bricompat. So these non-inferior trials has problems, and it's industry-driven, probably in 80% of them. So there are lots of factors related to the biases for these trials. If you look at the Bricompat trial, there is an increased ischemia-driven revascularization with PCI group, not with the CABG group, at 10 years. And however, our findings should be confirmed or refuted through adequately powered large-sized trials with long-term follow-up. So the Noble is in favor of CABG, and there is MACE in favor of CABG. Yes, it's driven by non-procedural MI and repeat revascularization, but it's a positive for CABG. Excel trial is the most definitive trial that we think. It has major strength with patient selection and strict follow-up, a good number of patients with reasonable age to know exactly the benefit of these patients. And in this trial, do you believe these are secondary outcomes? There was all-cause mortality 38% odds with PCI, not for CABG. And this is basically researchers counter this by stating the mortality is because of sepsis and cancer, and in open label RCT, the statement is very concerning. So the revascularization is significant in favor of CABG at this trial. The stroke, no difference in 5 years. So repeat revascularization is higher for PCI, is not a benign phenomenon at all, and it does associate with all-cause mortality in one of the subgroup analysis in Excel trial. So the myocardial infarction also has a big problem in this study. The universal dimension of MI wasn't included, and this basically not presented in the ESC and EACTS guidelines, and also not present in the 3-year follow-up either. So there is a 77% decrease in the procedural MI when using the definition of MI. So, and then it came in the news afterwards. The explosive story reports that the trialist concealed MI rates favoring CABG according to definition promised in the trial. And these are the factors associated with this trial. So there's an analysis done by C analysis, and they concluded there is analysis for these all pre-combat, syntax, Noble, Excel all together. The analysis estimated that 95% probability that the 5-year composite outcome of death, non-fatal MI, and stroke was higher in the PCI compared to CABG, and there is exceeded 1 additional death per 100 patients. And PCI was associated with inferior long-term outcome compared to CABG. So meta-analysis, all of them actually, if you use, if you do the right trials, the largest ones that has excellent follow-up, that has optimal patient selection, and hypothesis generating, you will have the right answers. And look at the right side.
Give 1 minute, please.
Please, 2 minutes if you don't mind. Please. So on the right side, favoring CABG, actually. And the superiority for CABG for mortality at 5 years follow-up. The largest registries, this is the Swedish registry, and it's basically 11,000 patients, and with median follow-up of almost 5 years. It showed, look at the right side, all for CABG, mortality benefit for CABG, MI, revascularization, MACE, all together. And they concluded at the end, CABG in patients with the left main was associated with lower mortality and fewer MACE compared to PCI after multivariate adjustment. And in this main compare, CABG outperformed PCI, especially in distal bifurcation left main. So in the osteal shaft, still target revascularization is in favor of CABG, but death, MI, and stroke is basically in the osteal shaft, no difference, but in the distal bifurcation is in favor of CABG. And it's very obvious. And look, the interventionist response after this. So if he's, okay. Anyways, so this is, I thought it's 15 minutes. Thank you so much.
Thank you.